Does that cover confusion, people? And stroke?
Yep.
So you got a lot of different things to work. I like calls like this. Altered LFC, because now I actually have to think, what's causing this? Do you have trauma? Is it medical? I mean, there are other reasons. There's metabolic reasons, like low sodium, water intoxication, can make you confused. It's not on here, and I have no way to test for it or treat it, but it certainly, it can happen. So, what's another neurologic problem? Let's talk about the old seizures patient. How many different kinds of seizure? Oh, and then with the stroke, there are two types. What are the two types? I'm either bleeding or not bleeding. It can be a hemorrhagic stroke. Okay, that's about 20% of them. And that's where a blood vessel burst upstairs. And then there's the more common ischemic stroke. That's 80% of them. And those are the strokes that we can do an intervention for and get the clot out or use a clot busting drug. But obviously we have to CT them first because we don't want to give a clot busting drug to somebody that's bleeding in their brain.
Oh, wait, what if we have a patient that has a blood thinner on a hemorrhagic stroke?
What was the question?
A blood thinning patient
Okay.
and they're having a hemorrhagic stroke.
There's we have a list of the blood thinners,
Yeah.
and then on the other side of the page is the antidote. Some antidotes work better than others.
Because you don't want them to clot.
Right, but we don't have any of those antidotes. But that's why that med list is so important.
Because they'll bleed and die
Yeah.
very quickly.
Okay.
So if I'm on a blood thinner, I just had, I have heart problems, okay? So I'm taking aspirin and Plavix. And now my blood pressure's uncontrolled and because I don't like my blood pressure medicine, or I got really angry, somebody wrecked my car and my blood pressure goes up and I bust a blood vessel up here. So now I've had a stroke. I've had what type of stroke? A hemorrhagic stroke. So now I'm doing this. You take me over. The first thing they're gonna do is CT me. It has to be done first because they need to decide if it's a hemorrhagic stroke versus a non-hemorrhagic stroke. If it's a hemorrhagic stroke, the TPA, the clot busting, that all goes out the window. Then they need to know, oh, it's a hemorrhagic stroke, and they're a blood thinner, which blood thinner are they on? Can we reverse that blood thinner to try to get it to quit bleeding? Or can we occlude that vessel? But if you occlude the vessel, then you sacrifice a chunk of brain. So, and you can also have subarachnoid hemorrhages. And as far as we're concerned, general public's concerned, it's a stroke. But it's a stroke in a very specific part. It's a stroke at the circle of Willis, almost always. I mean, you can have subarachnoid bleeds other places, but, whoops. Why is it not up there? Okay, not this one. Is it up there? Yep. So, we got our skull, we got our dura mater, subdurals and epidurals. And then we have our subarachnoid space, which, arachnoids, what are arachnoids? Spiders. So, it got that name because it's little spidery legs of the subarachnoid tissue, and then in between those legs is our CSF. So just think of it as like an underwater, passageways with all these columns, which is the subarachnoid space. So, here's circle of Willis. These are blood vessels come up, carotids, vertebrals, come up here, and they all interconnect, make a circle, which is a life-saving thing for us, because it gives us more balanced circulation, so to speak, in the brain. But every time there's a little bifurcation or joint in these blood vessels, okay, so I got a blood vessel coming up here, and it goes over here, and it goes over here. Wherever we have those connections, we're at risk for developing little aneurysms, little balloons in the tissue of the vessel. And if they break, then they bleed. And so this white stuff is blood that shouldn't be there. And that's the subarachnoid spaces. And this just highlights your circle of Willis here. You also have subarachnoid space all around and over the top. These are the most likely the hemorrhagic strokes, thunderclap headache. Because that blood vessel down there around the circle of Willis exploded. They're tiny, they're not very big, but they're in a really vital part of the brain, like around the brainstem. So highly fatal, 80% maybe. So that's the thunderclap headache, and so that's it's a type of hemorrhagic stroke, subarachnoid. Sometimes they survive, but often not. And if they do survive, they're very much affected for life by it. But that's, if you see the term thunderclap headache, oh, I've had headaches, but this one is the worst one I've ever had. And my vision is affected because what are the nerves for vision? They're part of your cranial nerves, and they're right around the brainstem. Speech, right around the brainstem. So that's why they have, eyes go off, deviate somewhere else. But if they say so, if you see the term thunderclap headache in a test question, it's a subarachnoid hemorrhage, and that's a type of stroke, and it's a hemorrhagic stroke. All right, so now we'll move on to, what are we doing? Ooh, we're running out of time. Seizures. Do we get called for seizures? Oh, by the way, CB says strokes are BLS, even though dispatch doesn't send them out that way. Because what's the treatment?
Transport.
Check the sugar, and if it's low, we try to give them some sugar. So with our patient Sandra here, if she's having a stroke, or if she's hypoglycemic, and that's why she's wandering around, not knowing people, and we check her blood sugar, and it's 55, how do we know if we can give them oral glucose?
Can you swallow?
Can they swallow? Or can they cough? One, they follow command, and two, if you need to protect your airway, what are you gonna do? Food goes down, if you're sipping on your drink and a little bit goes down the wrong way, you're gonna cough. In fact, you probably can't stop yourself from coughing. So if they can cough, you can give them oral glucose. You see any other treatments on there? What does that do for them? How are they different? They're not. You're just doing the nurse's job, that's all. So we took care of diabetics. Psych patients, that's Dee Dee's lecture. Overdose. All right. National curriculum says you give Narcan. We don't because they'll beat our ass. Or could beat our ass. Or go into withdrawal, and that's ugly. And I've done it to patients. And when you do that, just push it and step away. I like to do it just before I roll into the ER, and then the ER has to deal with them. Damn right. Yeah, we did that one time. It turned out she'd taken like a whole box of fentanyl patches and had them up under her boobs so we didn't find them. When they're real busty, that's a good place to hide them. And man, she woke up and yeah, she was not happy. I mean, E.B. Overchain was working in the ER, so E.B.'s like Tim is, good build, got some muscles on him, and they had 3 guys working there that looked like Tim. She also looked like Tim, without the beard.
Sorry.
Full mustache.
Yeah, she just had on one. She was also on the 3rd floor at Willow River. So that's why I did not wake her up upstairs. So it could be an overdose. They could be sick, could be the UTI, very common at the nursing home. Can happen at home. Did trauma, heat and cold exposure, usually we know if it's hot or cold outside. Hypothermia is a problem for old people. Their systems are slowing down, they're not generating heat like they used to. So they tend to get cold easy, and that's why their houses are like being in a toaster for the rest of us, because their metabolic systems are slowed down, they're not generating heat. And then there's the whole psych thing. Heart rate too fast, the heart can't fill, the blood pressure goes down. Heart rate too slow, doesn't circulate well, can affect your LOC. So let's go on to seizures. What do we know about
Can't stop.
them?
Not stop.
Can't stop them,
Unless ALS medication.
okay? They can be stopped with drugs. Are they usually stopped by the time we get there? Usually. They can't, rarely can they keep it going long enough because they gotta breathe, right? And they're using a lot of oxygen, so they're gonna get hypoxic. They're using a lot of glucose, they're gonna get hypoglycemic. And they're very tired afterwards. But usually it's stopped by the time we get there. So how do they present to us?
Confused.
They're not shaking, okay? They're confused, they're lethargic, they're not mentating clearly, they're not thinking good. So what is that state called? Postictal. I never heard of anybody being called, they're in their ictal state, but we do have an after ictal state. And the longer the seizure went, usually the longer the postictal state. Okay? So, at that point, they're really hard to assess because you don't know if they're gonna improve, which normally they should gradually improve. Yelling at them does not improve them. Wake up, wake up!
Stop shaking.
Don't shake them, they've already been shaking. Check their blood sugar. You try to get a 12 lead on them if they'll not pull everything off, and they're confused. You're not gonna be able to get this 12 lead, because they're not gonna be able to cooperate. If they start pulling stuff off. They may be a little hypoxic, might need some oxygen, so you put your pulse ox on. You check their sugar, okay? So they have epilepsy. They may or may not be taking their medications. The medications kind of dull you and they don't really like taking them. Or they may run out of them and think, well, I haven't had a seizure in 3 years, I'll just stop taking them. Well, the reason you haven't had a seizure in 3 years is because you were on medication. So what do we do for these patients?
Try to protect them if they seize.
Protect them if they seize,
Clear space.
clear space,
Get suction ready.
suction possibly. Pick their happy ass up, put it on the stretcher. How are you gonna put them on the stretcher?
And then they go move.
Supine, prone, semi-Fowlers?
Lateral recumbent position.
What was it?
Lateral recumbent position.
Left lateral recumbent position, okay, and what do we call that position?
Recovery.
Recovery position. So they're drooling maybe, or maybe they bit their tongue and they got a little bleeding in their mouth. If you lay them on their left side with their head facing down, their airway is open, the tongue is out of the way, and any blood or drool will just drool out onto the sheet. Okay, the recovery position, you learn it in CPR class. So they're postictal and they have another seizure before you get to the hospital. What do we call that?
No, that's good.
You starting to say it?
Status epilepticus.
Yes. Their status, which means not that they're shaking continuously, although they could. They have a seizure, they're postictal, and they have another seizure before they have a lucid period, before they get their full faculties back. That technically is status. And that's possible because we don't have any drugs at the BLS level that we can give them. The ALS level, we used to use Valium, I think they're going with Versed now. It works just as fast, I think, but it doesn't last as long, so we can get them off the drugs faster to find out what's really going on with them. Nothing you can do about it. You can't stop them. Now, sometimes we get called for seizure because you can see seizures, alright? So they have they do a little this and they fall out on the floor. Tim does he's walking and he does a little shaking and he falls to the floor. But he doesn't have epilepsy. Why did he have a seizure? He could have had a seizure for a brief little period of hypoxia or I refer to it as brain panic, because Tim's really gone into cardiac arrest. So sometimes they'll have a little seizure right when they first go into cardiac arrest, because the brain is like, don't die on me, heart. So kind of keep that in mind. If they just have a brief little shaking period, that it could be something else. It's not epilepsy. It's not really a seizure. It's just, the shaking is more of a symptom of something else, like cardiac arrest, hypoxia, hypoglycemia, drug overdose. Tim, don't overdose. You're too big for me to carry downstairs.
Yeah, that's
Now,
A little bit of that booger sugar.
Okay.
this page of the protocol book is what we refer to as the small text, and each protocol has a small text which gives you a little bit more information. Okay, alternate LOC and syncope are complex problems, that's why I like them, because they're interesting. Search for a cause. Okay, I can check their blood sugar, I can check their oximeter, I can check their pupils to see if they're constricted or dilated or wandered off somewhere. I can get a good history, maybe, med list. Prepare for a medical code, okay. Drugs and alcohol, we go to, Awful Arthur's at 1:30 in the morning. Could be alcohol, could be drugs, could be they have epilepsy and they really shouldn't drink alcohol.
No, it's definitely alcohol.
Can you be a drunk and have a medical problem?
Yes.
So don't just write them off as drunk. You can have more than one problem at a time. Could be trauma. At Awful Arthur's, it could be trauma. There's some run college kid mouthing off to a townie, gets sucker punched. Yep,
We
Been
had
there,
one fall
done
down
that.
the stairs.
Yeah, I fell on one stair.
Fell down the stairs and face planted.
Yeah, I fell on
Yeah, he also.
The hands in the pocket face plant.
oh,
He also.
mine fell out of a chair.
And then he jumped into the low scale hospital wall.
Yeah, he proceeded to try to phase through the wall.
See, this is a different patient, that's not the one I had.
No,
No, this was
we
interesting.
had one.
He was a little. We saw him graduate at the sandbox.
And then we saw him graduate with his master's in business administration.
That makes sense. That makes sense.
Tim,
Yeah.
you
Why
remember
did he
the
jump
lady-
into the wall? Did he see a door?
No,
No,
he just
absolutely
we told him to we wanted to move him from our cot to the bed, and he goes, "Huh."
He moved the wrong way?
No, he literally just like
We had.
he
our-
jumped from our stretcher to the bed,
Oh,
and the wall got in the way.
We were in a hallway bed,
The
so
wall kind of-
No.
he went too far.
He
Yeah,
hit
he
his
jumped.
head so hard against the wall that the patient in the room directly next to his bed woke up, and like you could see their eyes go as he hit his head on the wall.
He's a
He didn't feel it.
Good
So
guy.
if he didn't have
I'm
a head
sure.
injury
His
before
eyes-
he
good
got
guy.
there.
Yeah, good
he-
times.
He
Good
had
times.
two.
Good
One at the
times.
hospital,
Good
one
times.
there. Yeah. Do you know the lady that was at the ambulance that was like, "Oh yeah, my kid doesn't drink," and we were like, "That's what you think, mom." That was his mom. I swear, I promise you, that was his mom.
no
She walked up to his group right after.
She is.
It was
She
hilarious.
is lying to herself.
Hilarious.
That is something.
I was like, if only you knew. If only you knew.
Yeah,
You
'cause
guys
I-
also have to remember, if someone's taking epileptic medications, if they're drinking alcohol, it can
Lower
worsen
their
the
threshold.
side effects of it and
Yeah,
decrease the
that's
threshold
really bad.
for the seizures to happen, so.
So, okay.
Alcohol plus seizure medicine equals bad juju.
That makes sense. Alcohol plus
What do you
anything is
say?
bad juju's.
Yeah, I was gonna say.
Yeah.
Is that with any depressant or just alcohol?
Well, it's not
So,
good to
so
take.
what are some anti-seizure medicines that you might see?
Benzo? No.
Well, benzos, but they're short acting, so that's not a good one. To-
Versus benzo.
I don't know.
That's acutely how we get it to stop, but if you're an epileptic patient, what medications would you expect to see?
Downers,
Mm,
right? Like.
No, not Downer,
What is it?
specific medications,
Oh.
Dilantin,
Mm-hmm.
don't see it as often, they're newer, better drugs. Lamictal,
That's becoming a lot more
Well,
popular.
yeah.
Keppra is one. Don't they
Lamictal is
carry on
becoming very popular these
the-
days,
Keppra on the inside?
especially in juvenile epilepsy.
That'll be easy to remember, cause it sounds like.
Okay.
Dilantin, we had to check levels, it had to be between 10 and 20, it causes overgrowth
It
of
does
your
have a base
gums,
of some-
which is why you don't wanna
to-
take it for a long time. Tegretol,
Klonopin,
some Clonopins, it's not my
Depakote,
first one,
Depakote's one.
yeah. And if they quit taking them, what do you think happens? They're gonna have seizures. So the American Epilepsy Foundation says if a person has a seizure, but they haven't been taking their medicine, they really don't need to be transported. But I'm not gonna take their word for it, because I need to get them someplace where they can get their medicine. We used to we'd load them up on Dilantin at the hospital IV, which is risky. And then they get a script for Dilantin to get filled, and that's probably what didn't happen, because that's money. They gotta pay for that. So, look for a medical alert tag, which I have to admit, I often forget. I see probably more bracelets than necklaces. So don't forget to look at your small textbook or page. And then down in the pink we have pediatric stuff. So a kid passes out at a sporting event, be concerned. Particularly in kids. That is the most important question on a pre-sports physical. Have you ever passed out? Yeah, I passed out one time because I ran so fast. Oh, it means your heart didn't keep up. So, can't do much for seizures. Position of comfort, make sure their airway's okay, check their blood sugar, see if it's a correctable cause, get their medication list. Are you taking any medications? No. Are you supposed to be taking any medications? Yeah, I'm supposed to be taking Dilantin, but I couldn't afford it. It's a slightly different question. Are you taking, and are you supposed to be taking? Are there any medications that you're supposed to be taking that you're not taking right now? That's a different question. No, I'm not taking any medications because I can't afford them. Too expensive. They made me feel bad, and I quit taking them. So we've done strokes, we've done dementia and delirium, we've done hypoglycemia, altered LOC, we're gonna do head trauma in a different class, we've done seizures, finger stick blood sugars, GCS, stroke scale stuff. Any other questions? You ready to go out there, get these calls? And don't forget, a refusal is a tricky thing in this patient. Okay, who's next? I guess lunch is next, right?